Hi everyone, my name is Yujin Lee, and for those of you I haven't met, I'm one of the chief residents graduating on Friday. Today I'll be presenting phase 2 trials in intraoperative molecular imaging and focusing on those that I led during my T32 postdoc fellowship and during residency. I have no financial disclosures or conflicts of interest. So during today's talk, I'll present current and ongoing research in intraoperative molecular imaging in the resection of head and neck, primary tumor, lymph nodes, as well as visualization of normal anatomy, specifically nerves. I'll be incorporating results from these phase 2 clinical trials that I led during the past few years in Dr. Eben Rosenthal's lab, and also present my future directions in the field. I'll first start with primary tumor resection. This is an image of a patient with hard palate squamous cell carcinoma who enrolled in one of our trials. Our goal in oncologic resection in our field is to excise all tumor without positive margins while also trying to preserve form and function. These graphs show the rate of positive margins from 1998 to 2012. In the 10 most common solid tumors, comparing women versus men. And you can see here that there has really been no change in the positive margin rate for the vast majority of these cancers, with oral cavity staying at about 15%. And more recent studies since 2012 have not seen any changes in the rate either. And another study showed that despite more and more patients actually coming to academic centers, this positive margin rate hasn't changed. Positive margins are important because they are associated with lower survival, with studies showing up to 15% drop in 5-year overall survival in oral cavity cancers. It's also an indication for postoperative radiation therapy and or chemotherapy that has significant associated costs, up to $50,000. To address this need to be sure that we're actually resecting the tumor without positive margins, the standard of care is to use frozen section analysis and post-op histopathology. However, this is limited really due to the sampling limitations as well as the need for multiple samples, increased OR time, and costs. Frozen section analysis also is more challenging in our field due to the complex anatomy in the head and neck and requires a lot of phone calls back and forth with the pathologist, pathologist actually being called into the OR for orientation, or the oncologic surgeon leaving the case to go to the frozen section room to orient the specimen. And this is a picture of an example of a tumor specimen that Dr. Holsinger beautifully orients for every single cancer case. Over the past decade, more and more optical image guidance and devices, as well as radio tracers, have emerged, including fluorescent imaging, radio-guided surgery, optical coherence tomography, and ultrasonography. So first I'll go over currently FDA-approved agents for intraoperative guidance. So far, there are only 6 FDA-approved fluorescent agents. ICG, indocyanine green, was the first fluorophore approved by the FDA in 1956 for angiography of vessels, and then it was updated to include assessment of tissue perfusion and blood flow in various surgeries. In our department, Dr. Most has used ICG to study neovascularization after paramedian forehead flaps and has really shortened the time from dividing the pedicle from the traditional 3 weeks to just 1 week in certain patient populations. Dr. Michael Chang has also studied ICG to has used ICG to assess blood flow through the posterior septal artery and study tissue perfusion of the nasoseptal flaps in endoscopic skull-base surgery. Next, fluorescein was approved in 2006 for angiography of the retina and the iris. And then in 2016, methylene blue was approved for methemoglobinemia, but it's also widely used as an adjunct in sentinel lymph node biopsy. And then in 2017 is really the first time we see the first tumor or tissue-specific agent. 5-ALA was approved for glioma visualization intraoperatively, and this is the first specific indication for intraoperative imaging. In 2021, pafolacyinine Cytolux was approved for ovarian cancer intraop imaging. And then just last year, pegulocyanine lumicite, along with the associated device, was FDA approved for intraop imaging for residual breast cancer after lumpectomy. This is the list of optical imaging agents and their molecular targets currently in trials, and I'll present results from bevanicine and panitumumab IR 800 in the upcoming slides. There are also radiopharmaceuticals that are FDA approved. Only 3 are approved for intraoperative guidance right now, including indium pentatriotide for neuroendocrine tumors, and technetium-99 sulfur colloid, and tilmanocept for sentinel lymph node biopsy in breast cancer, melanoma, and oral cavity cancers. This is a list of radiotracers and their molecular targets currently in trials, and then I'll present these 2 agents that that were studied in trials here. And then this last one is interesting because it's in its own category, as the investigators actually conjugated girentuximab, which is an antibody targeting renal cell tumor, to both the radioactive metal and a fluorescent dye. So it's a dual tracer in one study drug. In the next few slides, I'll present research using panitumumab IR 800, shortened to PAN800. Dr. Rosenthal's lab has focused primarily on cetuximab and panitumumab that was conjugated to IR 800. These 2 antibodies target EGFR, which is overexpressed in squamous cell carcinoma. We transitioned from cetuximab to panitumumab mostly due to the improved side effect profile with panitumumab. The PAN800 optical imaging study was initially started at UAB and then continued and then opened at Stanford when Dr. Rosenthal came here. The trial was a phase 1 study looking at safety, pharmacokinetics, dose escalation, and they enrolled 64 patients who were undergoing head and neck surgery. As part of that study, they assessed peripheral margins ex vivo in patients who received 50 milligrams of PAN800. And working closely with our head and neck pathologist at that time, Dr. Brock Martin, we show that fluorescence intensity measured ex vivo correlated with the margin distance here on final pathology. Those with the highest intensity was noted to have the smallest margin distance. In addition, the lab showed that fluorescent intensity could be used for ex vivo tumor mapping, especially for the deep margins where we actually see more, where we find it more challenging. And the distance of the tumor tissue from the specimen edges were correlated with the fluorescence. And in all 3 dose cohorts in the study, the 0.5 milligrams per kilo, 1 milligrams per kilo, and the flat 50 milligrams, the fluorescence signal was present in areas where tumor was significantly closer to the margin edges than those areas without fluorescence. The ex vivo work and the correlation of the fluorescence intensity with margin distance allowed us to evaluate the role of the sentinel margin, which was noted to be the area along the specimen edges with the highest fluorescence intensity. This paper proposes a workflow for incorporating fluorescence intensity during the surgery, and also incorporates using frozen section analysis. So after the surgeon resects the tumor undergoes fluorescent imaging on the back table, and the areas with the highest fluorescence intensity would then be evaluated by the surgeon and can be clinically correlated back to the wound cavity. And if there was concern, then those areas could be sent for frozen section analysis. This study is ongoing at UAB, but showed the interim results of their phase 2 study using PAN800 for intraoperative visualization in TORS, transoral robotic surgery. And they showed that fluorescence imaging was able to delineate and was in line with the surgeon's defined tumor borders. It was also actually used to identify a piece of tumor fragment here that was kind of initially overlooked when using only white light imaging, but they were able to capture it on fluorescence imaging. This arrow is pointing to an autofluorescing bipolar forceps, so it's all in the context of dynamic context of doing the surgery as well. So now I'll transition to presenting data on intraoperative molecular imaging for lymph nodes. First of all, why do we care about nodal disease? Well, the presence of regional nodal disease is associated with lower 5-year survival, and you can see this drop in survival in oral cavity and laryngeal cancers. Our current standard of care imaging for staging nodal disease prior to treatment is CT, MRI, and PET, FDG PET. But these are all non-specific, so if they could be more specific, that would be great. FDG PET is the most widely used scan for tumor staging and targets highly metabolically active cells, and has been actually shown to have very high negative predictive value, 94% in this trial, but low specificity for head and neck cancer. In addition to the low specificity of FDG PET, the rate of occult metastatic disease in the lymph nodes is around 20 to 40, can go up to 20 to 40%, meaning these nodes are really not seen on preoperative imaging, and this also can lead to understaging and undertreatment for many patients. So in Dr. Rosenthal's phase 1 trial, we evaluated PAN-800 in the identification of lymph nodes, and these are examples of neck dissection contents by level that were imaged on the back table in the operating room for those who received the drug. This patient had multiple metastatic nodes on pathology, and this was consistent with the higher fluorescent intensities that you can see in some of the lymph node packets. Based on those this data set, we show that optical imaging with PAN-800 was able to distinguish metastatic versus benign lymph nodes with high specificity and sensitivity using mean fluorescence intensity here, as well as the signal to background ratio. And so given this finding of being able to distinguish metastatic versus benign disease, we evaluated the role of PAN-800 in sentinel lymph node identification. The usual standard of care for patients with clinically positive nodal disease is neck dissection. But for patients with clinically node-negative disease, elective neck dissections are discussed, or there's also the option of sentinel lymph node biopsy. Briefly, for those who are not as familiar with sentinel lymph node biopsy, it's an important technique for evaluating regional metastatic disease and cancer. The sentinel nodes are the first few lymph nodes to which the cancer directly spreads by lymphatic drainage. The technique involves injecting a radioactive substance or a dye around the tumor. And prior to surgery, the patients undergo lymphoscintigraphy to identify the sentinel lymph nodes on imaging, on SPECT-CT. And then intraoperatively, we can use a probe to detect the radioactivity, the gamma counts. And then also, if a dye has been injected, that can also be used to actually visualize the sentinel nodes in the surgical field. Then these lymph nodes are excised and sent for pathologic analysis, and it helps to stage the cancer without extensive nodal dissection. So this is like standard of care for melanoma, breast, endometrial, and penile cancers. In head and neck surgery, this is becoming more widely used for oral cavity cancer and is actually the standard of care in some countries. The main limitation within our field is access of these primary tumors for local injection, because you can imagine that some of these injections would be very, very uncomfortable for an awake patient. And if we're talking about other tumors within our field, it'd be very hard to actually inject patients with base of tongue or laryngeal cancer while they're awake. Another limitation that's currently used, another limitation of the currently used locally injected tracers is that it's really dependent on whether you have intact lymphatic drainage pathways. In patients who have had radiation or prior surgery, the sentinel lymph node biopsy with the current method can be inaccurate and give false negative results because of the disrupted lymphatic drainage pathways. So we looked at how PAN-800 could potentially be used for sentinel lymph node mapping. Patients who underwent nodal dissection in this study had all of their lymph nodes imaged and ranked based on their mean fluorescence intensity. So this is 1, 2, 3, 4, 5, the top 5 nodes with the highest fluorescence intensity. And we found that all the lymph nodes that were positive for metastatic disease were identified within the top 5 nodes based on the fluorescent intensity ranking. In the clinically node-negative cohort, 90% of the metastatic nodes were found within the top 3 rankings. And then in the clinically node-positive group, or about 70% of the nodes were ranked within the top 3, but they also had more nodes that were positive. The previous study also evaluated several patients who underwent lymphoscintigraphy with the 99 technetium tilmanocept, also called LymphoSeq, in addition to the PAN-800 infusion. In one of these patients, which is the example here, the sentinel node identified by LymphoSeq actually was negative for disease on final pathology, which correlated with the low MFI as seen on this, the mean fluorescence intensity as seen on this fluorescent imaging here. However, the PAN-800 was able to identify other lymph nodes with higher fluorescent intensity, and even though these were not considered sentinel nodes because they did not have the gamma rays, gamma counts, these two nodes were the top. This was the top one, and then the top third lymph node with the highest fluorescence intensity, and these were shown to have metastatic disease. So this suggests that perhaps a systemic infusion of radiotracer could potentially improve identification of the sentinel nodes. So one of the limitations with PAN-800 or any fluorescent tracer is the limited penetration depth, requiring the whole a wider surgical field to be opened up in order to visualize the deeper cervical nodes. So we conjugated 89 zirconium panitumumab, the antibody used in PAN-800, to see whether we could still detect these lymph nodes intraoperatively by detecting the beta rays that are emitted by radioactive decay. And these beta rays are also captured on our regular PET scanners. So we also obtained the zirconium PET scans preoperatively. So overall, based on this trial, we showed that 89 zirconium panitumumab detects head and neck squamous cell carcinoma with high specificity, up to 96%, when combined with the FDG PET in the preoperative setting. So going into a little bit more detail about the clinical trial, because this is the main trial that I led during my T32, we enrolled 14 patients with head and neck squamous cell carcinoma undergoing standard of care surgical resection and neck dissection. And during routine pre-op evaluation, the patients underwent FDG PET. After enrolling in the trial, they received 1 millicurie of 89 zirconium panitumumab, and after 1 to 5 days, they underwent the zirconium PET scan and then the routine scheduled surgery. In order to evaluate the sensitivity and specificity of 89 zirconium panitumumab, we collected maximum standardized uptake values, which are the quantified PET signals, for all tumor and lymph nodes, and compare this to the gold standard final pathology. Early on in the trial, we realized that a major limitation of zirconium panitumumab is actually the beta rays that are emitted, because there are no widely used intraoperative devices to actually capture the beta rays. So this study drug was really limited to the preoperative setting at this time. Here we showed the feasibility of zirconium panitumumab to detect primary head and neck cancer compared to the standard of care FDG. The top row shows the tumor in blue, the oral cavity tumor in blue, which is correlated with the zirconium PET scan. And the bottom row, the blue shows the tumor of a different patient, and the orange shows the lymph nodes that were detected on both scans. It's interesting to note, though, that the lymph nodes identified on the FDG PET scan shows 1 metabolically active node here, but on zirconium PET, there were actually 2 nodes that were identified, and the second one was noted to be necrotic, so not as metabolically active, but still had EGFR expression, so that potentially explains the discrepancy in the findings. These images show the specificity of zirconium panitumumab on preoperative imaging for squamous cell carcinoma. In the first row, the patient had mediastinal nodes that actually had some FDG avidity, and the patient actually underwent endobronchial biopsy, and these were negative on pathology, which was consistent with a negative zirconium PET scan. And then in the second row, the patient had a prosthetic joint that showed some FDG avidity around the shoulder that was seen on FDG PET, but of course, we don't think that this is cancer, so clinically, this correlated with the negative zirconium PET scan. The third patient was actually very interesting because he had T4 oral cavity cancer and was treated with neoadjuvant chemo and immunotherapy. And he actually had a really great response. So this FDG PET scan is after the chemo and immunotherapy, but before surgery. And it shows some FDG avidity in the tongue. But on final pathology, he did not have any tumor in the tongue. So this was in line with the negative zirconium PET scan as well. So again, overall, we show that combining both the FDG and the zirconium panitumumab PET CT improves specificity for head and neck squamous cell carcinoma. But again, this is limited to the preoperative setting, and I wanted to find something that was more in the intraoperative setting to help with the decreasing the positive margin rates. So we discovered that we could have a molecular targeted tracer for both pre-op and intra-op detection by conjugating panitumumab with 111 indium. And preoperatively, we could use SPECT-CT, which is commonly used in all hospital settings, and then intraoperatively detect the gamma counts, which is, again, also widely used in surgery. The trial included patients with head and neck squamous cell carcinoma who were scheduled to undergo primary tumor resection and neck dissection as part of their standard of care again. And eligible patients received systemic injection of 111 indium panitumumab. Intraoperatively, the patients underwent local injection of a standard of care dye, ICG or methylene blue, to perform the sentinel lymph node biopsy. And then the neoprobe was used to detect the gamma counts. And then the patients underwent full neck dissection as standard of care. At Stanford, we actually enrolled a total of 6 patients. The first 2 patients were excluded because they did not receive a loading dose of the unlabeled panitumumab, and so we didn't have any. We weren't able to generate data. But then we amended the study to include a loading dose, and we have data from 4 patients so far from Stanford. But since 2022, the study's been on hold because they've been remodeling the cyclotron facility, so the study drug production has been on hold. But when Dr. Rosenthal moved to Vanderbilt, we opened the same study there, and I've been working with them still, and they've enrolled a total of 17 patients so far, so I'll present data on those patients. And they've shown that the signal to background ratios of the gamma counts for the malignant lymph nodes were significantly higher than the benign lymph nodes ex vivo. This is a receiver operating characteristic curve of the signal to background ratios, showing a sensitivity of 90% and specificity of 80%, but with a negative predictive value of 99%. This is an interesting example of how sentinel lymph node could be used to restage instead of proceeding with a full neck dissection. This patient was a 37-year-old patient, clinically staged with as a T3N2 based on imaging. And the patient underwent systemic injection of the studied drug and also a sentinel lymph node biopsy. And in neon green are the 3 sentinel lymph nodes that were identified by ICG. And these were also the ones that had the highest gamma counts. And all of these nodes were actually negative on pathology. So based on this, just the sentinel lymph node biopsy, the patient would have been staged as an N0. And then the patient actually underwent the full neck dissection as part of routine standard of care. And the pathology, after accessing all of the lymph nodes, was N0. So the final stage, T2N0, correlated, or at least the nodal stage correlated with the sentinel lymph node biopsy. Our studies of using 111 indium panitumumab in vivo, though, has shown mixed results. We saw a lot of variability in the gamma counts in the wound cavity. So, for example, we saw expected decrease after resection, which is what we use in standard sentinel lymph node biopsy. But then we also saw unexpected increase after taking out the metastatic nodes. So we still need to do more research to evaluate these high background counts, which is very important in the standard workflow for sentinel lymph node biopsy. So next, I'll be shifting gears a little bit to present a phase 1 and 2 trial evaluating a new optical nerve-specific tracer, bevanicine, for intraoperative nerve visualization. This was a multi-institutional trial that was a first-in-human clinical trial using a nerve-specific tracer and was conducted at UCSD, Stanford, and also at Mass Eye and Ear. There were 2 cohorts, a dose-defining cohort as well as a dose-timing cohort to evaluate the time from infusion to surgery. And preoperatively, patients received an IV administration of bevanicine, which is the nerve-specific peptide conjugated to fluorescein. And then intraoperatively, we collected white light images as well as fluorescence images, and also performed other metrics as well. Adults without significant comorbidities with a head and neck neoplasm were included in the trial, and they underwent parotidectomy, thyroidectomy, and or neck dissection. And any patients with history of chemoradiation, prior surgery, or allergy to fluorescein were excluded from the trial. A total of 27 patients were enrolled, 15 in the dose-defining cohort and then 12 in the dose-timing cohort. About half the patients underwent parotidectomy, a third underwent neck dissection, and the rest underwent thyroidectomy. There were no serious adverse events associated with bevanicine, and the serum half-life of bevanicine was found to be around 30 minutes. So this is something that you can use immediately pre-op to your surgery. So here are some representative images from the trial that highlight the improved visualization of nerves. This is an example of a facial nerve with improved contrast on the fluorescence imaging. This is actually a paired white light with fluorescence overlay, so you can see more of the colors. And then in this static image, we see the nerves are not readily identifiable, but of course this is a static image, right? When you're operating, it's always dynamic. But when you pair it with the fluorescence imaging, you see improved visualization of the additional nerve branches. And then in this final pair of images, we see the main trunk of the facial nerve on white light imaging, but with fluorescence imaging, we see the additional nerve branches with a thin overlying fascia. And then this is an example that sorry, there's a video. Okay. Let me change to a pointer. So this is an example of tracing the facial nerve branches using fluorescence imaging intraoperatively. Even though you get into bleeding here, you still see the nerve. I wasn't doing this. But you can see that you can really switch back and forth seamlessly with fluorescence imaging and white light imaging. So in order to more quantitatively measure the visualization characteristics after the drug infusion in a more meaningful and clinically meaningful way, we used the visualization scoring system, which was a metric that was used to evaluate the MRI contrast agent gadobutrol before they were approved by the FDA. We focused on contrast enhancement, branching delineation, and the total length of the nerve measured. And we show that compared to white light imaging alone, using both white light and fluorescence imaging, the paired images, significantly improved contrast, length, and branching delineations on a per nerve and per subject basis, which took into account the correlated intra-subject data. We also showed that on a per nerve and per subject analysis, there was greater than 20% improvement in total length of the nerves that were measured in the majority of the patients in the study. So in conclusion, we showed that bevanicine is safe with a half-life of around 30 minutes. In our dose-defining and timing cohorts, we found that 500 milligrams of bevanicine infused 1 to 5 hours prior to incision generates adequate fluorescent signal with improvement in contrast, length, and detection of additional nerve branches. This was recently accepted in Nature Communications, and I just submitted the proofs over the weekend, so it's very exciting. And I'm very grateful for all the support from the department, the CSCP, all my mentors, for all the lessons and skills learned during my T32 postdoc. Specifically, I had firsthand experience starting and completing investigator-initiated trials, from protocol design, approval, enrollment, data collection and analysis, and publication of the results. I also had invaluable experience working with the FDA and also working with industry for sponsored trials. I also learned that research requires a lot of patience, persistence, and flexibility. I started my T32 right in the middle of the COVID pandemic. Also, my PI leaving for another institution in the middle of my postdoc. And then also with the cyclotron remodeling, delays in the study drug production. But I've learned a lot over the past several years in residency. And then another big takeaway for me has been that who's on your team matters a lot. I received a lot of wonderful mentorship and guidance throughout, and I would not have been able to achieve everything I've done without the people on my team. So starting July 1st, I'll be continuing my surgical training in advanced head and neck and reconstructive surgery at UPMC. And I'm excited to be a co-PI for the phase 3 trials with bevenecine there. I've also written a protocol for an investigator-initiated trial evaluating voice outcomes after thyroidectomy after using the bevenecine. And I'm excited to get this trial up and running once I start at UPMC. Going forward as a junior investigator and clinical trialist, I'm interested in continuing to pursue intraoperative guidance, especially in cases after neoadjuvant therapy. So I don't know if you remember the patient that I presented with a really great response to immuno and chemotherapy. As there are more neoadjuvant trials coming up, I think it's going to be a really important question of like, what is the extent of surgical resection? Because that is a goal for doing these neoadjuvant therapies, is to limit how much we're actually removing. So I think intraoperative imaging is going to be very important in kind of answering those questions. So I'm excited to continue doing that with PAN 800 and some of the radio tracers that I've worked with. And then I'm also interested in using zirconium panitumumab also in the preoperative setting for initial and surveillance imaging because it is very tumor specific. And I actually already designed the protocol and had it approved at Stanford, but because of the study drug production delays, we haven't been able to enroll. But that's okay. So overall, I'm interested in continuing to shift the current surgical paradigm of just using our hands and eyes to actually incorporating intraoperative molecular imaging to improve patient outcomes, so that this positive margin rate can really start to come down. And I'm also interested in pursuing cost effectiveness studies to show that these studies are actually, the agents in these studies that we're doing are actually worth it for our medical system. And then one of the other things that I'm also interested in is kind of working to streamline these clinical trials and imaging, because they're usually less risk compared to like therapeutic trials. And so kind of working in like a center for precision surgery like Penn. Again, I'm very thankful for all the support I've had from the department, as well as all my mentors, especially Evan, who's been very instrumental in giving me a lot of these opportunities. And thank you to the Head and Neck Division, the clinical trial coordinators, the CSTP, all of our associate investigators from nuclear medicine, medical oncology. Thank you to all the department faculty for all your patience and teaching, as I have grown a lot over the past 7 years. And thank you to my co-residents for surviving residency with me. I also wanted to thank my family and my parents, who have really supported me throughout all my life, and basically also raising my 2 kids. Thank you.